you talked about the legislation and the changes, and we'll just start with Medicare for right now, because private insurers, I think, have either been half a step ahead or half a step behind or somewhere between Medicare. But I think the big driver was the buy-in from Medicare. Each one of you guys, I'm going to start with Dr. Gore, had the buy-in from Medicare affected somebody as much in an academic center? I certainly that, I know that in a private practice setting, we had been, hanging on every single word of the legislation. We'll start with Dr. Gore. When Medicare sort of relaxed its rules, did that make a big change for you guys in an academic center?
It absolutely did. So personally, about 55% of my practice is Medicare patients. And I will tell you, in recognition of the pandemic, personally, in my own practice, I had made a decision to large-scale convert to telemedicine, irrespective of payer, but it became a no-brainer when Medicare massively relaxed the regulations, especially around place of service, so patients could be in their own home. One of the big things that Medicare said is that they're not going to audit whether a patient has been seen in your clinic before. They're not really explicitly saying that they're giving you permission to do new patient visits, but they're also not going to try hard to look for it. So it allowed us to continue to see new cancer patients that were Medicare patients without having to be concerned about reimbursement. Another big factor for us at the University of Washington is we're the only university-based academic center, comprehensive cancer center for what's called the WWAMI region, which is Washington, Wyoming, Alaska, Montana, and Idaho. And one big limiter in our provision of telemedicine for our catchment were the interstate rules around telemedicine, and some relaxation of the interstate rules by Medicare was also a great boon for us to continue to see some new cancer patients and to continue to have touch points with our established cancer patients.
Okay. Dr. Spitz?
Yeah, so the lifting of regulatory and payment constraints by CMS was absolutely revolutionary, and I think it set the state of telemedicine ahead by many years, to be honest. And payment, I think, is the biggest barrier to entry for most doctors for telemedicine. It's not that telemedicine is so difficult to do, it's that why bother if there's no reimbursement for it and you have to spend time communicating with your patient and providing care? Why go through all the trouble? And now that that disincentive has been removed, it has basically enabled so many of us to adopt telemedicine, and it's certainly enabled my practice to adopt it. Fortunately, Medicare has now explicitly stated they will pay for new and established patients. And this has enabled our practice to partially remunerate ourselves for the lost income that we're all suffering with the stay-at-home orders. And the fact that Medicare is willing not only to reimburse, but reimburse on par with in-office and remove the barriers to reimbursement by allowing that reimbursement to be based on medical decision-making and not on a physical exam, which, of course, we can't accomplish telemedically. These kinds of reimbursement strategies that have been recently rolled out have dramatically improved our ability to provide care for our patient while continuing to maintain some fraction of our compensation. Of course, as proceduralists, there is a significant amount of care that we cannot provide telemedically, and likewise a significant amount of reimbursement that we cannot capture. And so there is really no way around the fact that there is economic hardship for particularly those of us in private practice that don't operate on grants or larger institutional funding. But Medicare is certainly reaching across that divide to us with the reimbursement for telemedicine, with the advancement of Medicare payments, and also the government in general with the CARES Act. So it has been absolutely critical to see this lifting of the payment restrictions. And then the lifting of the HIPAA requirement is equally important, because there are many of my patients who either don't have the sophistication to engage with my commercial telemedical platform that is HIPAA compliant, or there have been glitches in the system. But the majority of my Medicare patients use FaceTime or Skype to speak with their family members, their grandkids, what have you. And to be able to toggle over to that immediately in real time has been fantastic. And for those that can't really accomplish either the HIPAA compliant or non-compliant audiovisual platforms, Medicare is paying for telephone calls, albeit at a reduced rate. But nonetheless, this is a dramatic improvement from the previous situation, which phone calls were not covered. So they've really given us the tools to, at the very least, have a continuity of care. It's not perfect. There are definitely patients that still require hands-on, and our practice still sees patients in the office for those urgent needs and in the hospital for those urgent needs. But it has been a huge Band-Aid.
The audience that's here today, I'm going to make a big assumption, but I think I'm going to be pretty correct that the level of sophistication is starting out. And I don't want to intimidate folks. What's happened is really an enormous amount of relief for all of us who've been doing this for a long time. And that is really about the 4 Ps. One is the providers. The providers, it's a lot of people. It can be clinical social workers can be doing telemedicine. It's about the patients. The patients-wise, they're now not only just new established patients, but it's new patients that can be seen. Third is the payers. The payers now are seeing the relaxed compliance and the ability to bill in order to make this happen. And finally, the privacy issues. The privacy issues that were really coming up to a major wall has really opened up now in the way that I think it'd be easier for our patients to, whether it may be a phone visit or if it's video visit, that it's easier for our patients to be seen. And so I think that from a simplistic point of view, there's a lot of detail in each of these, but everything has been lifted in a way that's been an amazing, remarkable transformation. The genie's out of the bottle. We're not going back in. I think that the next question you're going to ask sometime is about what will stay after in a post-COVID-19 world.
Now we'll get to that a little bit later. I want to touch base really quickly about the codes. Now again, I'm going to talk majorly about Medicare. So in the bottom right-hand corner, apparently you can see this slide. So for billing and for people who haven't done this yet or have questions about what codes need to go out, Medicare and most private insurers also will pay for, whether they pay your new or established patients, but Medicare will pay for CPT codes 99201 through 99205 for new patients, 99211 through 99215 for established patients. And just like Dr. Spitz said, they were trying to remove any incentives to bring a patient out of their home and into the office, because they probably understood that doctors would probably risk bringing patients into their office if they knew the payment was going to be a little bit better. But so they wanted to make sure there was no incentive to bring a patient in. They wanted patients to stay at home for the good of the health of the country. So they wanted to give payment, to make the same payment, whether the patient was seen in the office setting or at their home, same payment. So therefore, we'll use the same codes. Now, one thing is that doctors need to realize, or the practice managers need to realize, that you'll use the place of service, do billing and coding, of the location that you would have seen the patient if they had come into your office or the same setting. So, for example, if you see somebody in the office, it's a place of service 11, no longer place of service 2. Place of service 2 for Medicare was when a patient was in an originating site and the doctor was in the distant site, and you just get the facility payment for the distant site, which is a little bit less than a regular office payment. So make sure you use place of service 11. You have the same payment for the same code, whether the patient is at their home or whether they were to come into the office. But one other thing that Medicare did, which Dr. Spitz also mentioned, was that they made, again, so they didn't want to try and incentivize someone to bring in, like, oh, we won't be able to build the higher level codes because we may not be able to reach the physical examination codes, the numbers of buttons that we need to click or the number of items that we need to examine. So they took away the need to perform a comprehensive history, and they took away the need to perform a comprehensive physical examination, so that when you're choosing a code, level 1 through 5, it's purely based upon medical decision-making. Same medical decision-making chart as we've used through 1995 and 1997 guidelines, whether it's a new patient or established patient. So once again, if the patient has the medical decision-making of being a level 4 or 5, but you can't hit all the buttons to get the physical exam to get that number. It doesn't matter. You do it purely based upon medical decision making. And they also changed time. Typically, when billing for time, it was total time face-to-face when more than 50% was counseling and coordinating care. Currently, when we use time, you could, on the same day, the pre-operative, the pre-service work, so if you prep the chart that morning, you can add that to the amount of time you're spending with them on the visit, and the amount of time that you're spending minutes-wise after the visit doing all the work that you may need to do. If you type that all into your note, the total summed time is the time that you will use, but please make sure you put it in the note. So I think that's really important. Dr. Spitz also mentioned phone calls. So again, Medicare will pay for phone calls. And again, we did see, and probably all have seen, populations where somebody does not have access, does not have a smartphone, does not have a computer with an appropriate hookup, and they can get some of these video features. As Dr. Spitz said, the phone calls themselves pay a little bit less, but you can do an evaluation and management service by a phone call also. So just want to make sure everyone kind of understood those nuances, because if you don't read every single word in that huge interim rule document that Medicare laid out, you may miss some of those little nuances.